Αγαπητοί συνάδελφοι, καλή σας μέρα. Είναι μεγάλη μου χαρά να προεδρεύσω σε αυτή την ομιλία του προσκεκλημένου ομιλητή. Ο Νίκολας Χάρτ είναι από τους πιο γνωστούς πνευμονολόγους αλλά και εντατικολόγους στο Ηνωμένο Βασίλειο. Είναι honorary reader στο King's College. Έχει ένα πολύ σημαντικό ερευνητικό έργο αλλά και πάρα πολύ σημαντικό κλινικό έργο και θα μας ξεναγήσει στο πώς μπορούμε να αποφύγουμε ουσιαστικά τα προβλήματα από τις παροξύνσεις της χρόνιας αποφρακτικής πνευμονοπάθειας. Νίκ.
Good morning, ladies and gentlemen, and I'd like to start just by expressing my sincere thanks. My sincere thanks to the organisers who invited me, and also to obviously the president of the society, Professor Zakinthanos, but also to some friends that I've had for many years, and that's for Nicholas, who hosted me yesterday with my new colleague who's working in London, which is Georgios Kaltsakis, and we had a phenomenal time. Not only did I visit a hospital, but I went to see some cultural elements of Athens, which has been a fantastic experience. So thank you. I'm obsessed, and I'm obsessed by COPD, like many people, but I'm obsessed by COPD because it is a disaster. We see more patients admitted with COPD within our hospital on a regular basis. Across our two hospitals, we have about 1,000 COPD admissions a year. Of these COPD patients, a significant number are coming back at 14 days, 28 days, 3 months, and within that first year. We need to get better. We need to get much better at supporting our COPD patients to ensure that we can keep them out of hospital. And that's really the avenue I want to talk about today in terms of the COPD patients. About 10 years ago, we set up a physiology program, and I'm delighted to be here in Athens and be in Greece because physiology is key here. Physiology is entrenched in training. Physiology is part of the whole respiratory culture. Unfortunately, in the UK, we've become molecular biologists, but we need to bang the drum for respiratory physiology. And so we were very focused on looking at neural-respiratory drive, see how it related to breathlessness, and then see how that relates to the physical function, quality of life, and then more importantly, into cost-effectiveness. So we've got a whole team that's working on these types of projects. And when we think about COPD, we think about biomarkers to predict outcome, and there's a whole industry around biomarkers. And this is taken from the New England Journal from 2012, and it's the last sentence that really gets me. It's, despite such progress in which a physician uses biomarkers, recapitulates an enduring practice of medicine, measure the patient, think about the result, and make a decision. That is the drive around biomarkers. Unfortunately, when you think about the biomarker, it's slightly disappointing to see this is generally a substance or a molecule. We're physiologists. I want to see a physiology biomarker. And when you look at all the biomarkers that have been through to try and prevent or predict admission prevention in COPD, none of them showed a way through for us. This was not helpful. So let's think about an advanced physiological biomarker, and I don't think it is generally a substance or molecule. I think we need to have a diagnostic tool, and we should be thinking about treatment failure rather than treatment effect, because it's actually treatment failure that results in readmission in COPD. So we set up the Advanced MyoTrace program, which was measuring neural respiratory drive. And really what this was an objective marker of breathlessness. That is what the drive was when we set this up. And so we know the difference between the symptoms of the patients of breathlessness and the sign of dyspnea. And what we wanted to do was take the measurements. We wanted to take measurements in patients and see how it related to clinical outcome. We wanted to translate physiological science into clinical practice. And so why is this a big driver? Well, there's a huge financial consideration within COPD. COPD exacerbations and readmission to hospital cost a significant amount of money. and in fact this is even worse in the UK system now, we get penalised if patients get readmitted within 28 days. So there's a financial levy and a financial penalty placed on the trust if the patient gets readmitted. So it's a priority. It's a priority for the managers. But it's a priority for us because we care for patients. And every time a patient gets readmitted to hospital, they get a fall in their health-rated quality of life, they get a fall in their exercise capacity. And patients that have more than 3 exacerbations a year are likely to be dead at 5 years. We need to stratify these patients, we need to identify these patients in order that we can help and secure their outcome. So when a patient comes into hospital, and this is where the physiology is required and a knowledge of physiology, he has an exacerbation of COPD. Well, the exacerbation of COPD will lead to an increase in neurorespiratory drive because there's a threshold load on the system. There's also a resistive load pushed on the system, and there's reduced capacity. The diaphragm function, the diaphragm's flattened. The law of Laplace says it can't generate the same amount of pressure because the radius is increased. Now, we all know that. We're physiologists. And what happens when we give a treatment? We see a reduction in the resistive load. We see a reduction in the threshold load, and we see an enhanced capacity. And that's really key. And this balance between load, capacity and drive is key to our understanding when we're thinking about how we look at exacerbations of COPD. Now, we spent a career doing esophageal monitoring. It can't be done in the acute setting. We have actually tried. It doesn't work. What we've moved towards is using parasternal EMG. Parasternal EMG is a non-invasive technique, and the parasecond intercostal space parasternal is a surrogate marker for the diaphragm. So this is a key element in the process or the monitoring and measurements that we've taken. And it's really straightforward. You look at the parasternal EMG, and as you see here, you see the parasternal EMG rise and fall. Unfortunately, those rather annoying ECG artifacts seem to get in the way, but we've actually managed to remove those. But what we then do is a root mean squared. So we take the electrical activity, we do a root mean squared and measure the peak activity. And from then, we can do the tidal breathing, and then we actually normalise it for the sniff manoeuvre. Patients coming in with an exacerbation of COPD have coryzal symptoms. They have cough. Sniffing for them is not a problem. So when you ask them to do a sniff manoeuvre, you can get the maximal EMG, you have their tidal EMG, so we can have a proportion of maximum in terms of the neurorespiratory drive, and if we multiply by respiratory drive, we get neurorespiratory drive index. This was a study we did early on. We did a study early on in terms of just measuring the EMG, the neurorespiratory drive, from admission to discharge. That's all we did. We looked at admission to discharge to see whether there was a difference. And what we found is there was a group of patients had a fall in their EMG from admission to discharge, and those patients where it didn't fall or even it went up. And those patients where it went up were likely to get readmitted to hospital. This was a selected study. This was 30 patients. They were hand-selected in terms of, a pilot study. So this is more of a kind of a 2A, 1 to 2 study. It was really just to get the information that we would then use to move on. But what we found is that the change in EMG in terms of the neurorespiratory drive index and the neurorespiratory drive was different between the groups. But as I say, it was a limited study. And when it's a limited study, you go on and you think to yourself, well, let's do this in a bigger study, an unselected study. So we measured neurorespiratory drive following hospitalisation, and we did admission to discharge neurorespiratory drive. This time we did it in 120 unselected COPD patients. We took every patient coming through the front door of the hospital. This led to over 600 studies and 122 patients. This was a complete comprehensive endeavour by Dr. Isik Su, who's one of my consultant colleagues in the Lane Fox unit. We had the usual array in terms of the type of patient with COPD. These patients were 70, they're predominantly more male. The interesting parts I want to highlight is the hospital admission frequency beforehand, these are median values, was 1. The duration of symptoms was 4 days. You go through the literature and you'll find out a patient is exacerbating for about 4 days prior to admission. That's key. That is a targetable area, and that's where we need to start thinking how we prevent admission in COPD. And when you think of these patients, you know, the majority were gold stage 4 by definition. And when you look at the deaths within 28 days, you see deaths were low, but I'm more interested in readmission rate, which was at 22% at 28 days, and in fact it was 13% at 14 days. So the most patients are being readmitted within the first 2 weeks. When we look at the data, and we look at it in terms of logistic regression analysis, what we found is that 28-day readmission was predicted by a change in EMG, and those under 85 were very much more the group that we were focused on. And when we look at these data, what we see is if you had a 3.1% fall in your neurorespiratory drive from admission to discharge, as displayed on this Kaplan-Meier, then you were more likely to have a safe discharge. Indeed, the negative predicted value was 98%, and I'm going to say that's a safe discharge. This was not, because the prevalence of the condition, as in readmission, is only 20%, which is low, your positive predictive value will never be very high. But this is the whole idea of using statistics in clinical practice to risk stratify our patients. And then these are data that are currently under review. We've looked at the data in terms of mortality, and you see here, if the EMG power percent max was less than 15% or greater than 15% at discharge, i.e. high, low versus low ratio, then the mortality was worse in the high group. And this is obviously mortality. We had a median follow-up here of 3.6 years. Most importantly for me is I want to know what the elements or risk factors are. And what you see here is that when we're looking at neural drive, that was a useful in terms of this logistical regression analysis that we did. But more importantly, that's a modifiable factor. We have pharmacological and non-pharmacological interventions, and we're currently doing a phase 2b trial, which is using high-flow nasal air on discharge from hospital to try and reduce the neural respiratory drive. We've got targeted treatments to neural drive. I can't change age. CO2, in fact, when you look at this, although its predictor here was only 6 for these patients, so they wouldn't qualify for home ventilation. And LTOT, well, that's a marker of how bad your lungs are, and I can't modify that. So we need to look at modifiable factors. To be fair, when we've done this, this is absolutely time-consuming. It's hand analysis, so it has limited clinical ability. However, we've developed an algorithm now. We've worked with Philips Research to develop that algorithm, and that algorithm now allows an automated approach to making the measurements. And so what we've really got is, let's not think about molecular biology. Let us think about how physiology needs to be driven into clinical practice. And this is how we will do it in terms of measuring neurorespiratory drive and using translational physiology to design the future trials. I can tell you what we've learned is we've got a target population. I know what that is now. We've got an intervention, which could be molecules and drugs, but I'm more interested in non-pharmacological support of these patients. And then we know what the primary outcome or the core outcome measures that we're going to measure, which is either mechanistic, patient-centered, and health service, so cost effectiveness. So we want to promote safe discharge. We've got a therapeutic target, which is neural drive. We've got a target population, which is severe COPD. And then we've got this therapeutic intervention, and we want to unload the respiratory muscles further to reduce the neural respiratory drive. And with that, we can have the core outcomes set. Now, this is obviously a group of patients where we want to prove cost and clinical effectiveness, and we've done that by making measurements, and those measurements have ensured that we understand more about our patients, and we understand more the deep phenotyping of these patients within our clinical practice. But these are a group of patients which have non-hypercapnic respiratory failure, and I've said how quickly these patients come back. Now, if you have a patient who has acute hypercapnic respiratory failure requiring non-invasive ventilation, their readmissions are even greater. And so we've undertaken a trial which we published last year in JAMA, where we looked at the whole idea of using home ventilation and home oxygen therapy to reduce readmissions in COPD. This was presented at the ATS in 2017, and indeed it was in the JAMA New England session, and my colleague Dr. Patrick Murphy delivered it then. This is, for us, data that has been really important and long awaited. We knew that acute non-invasive ventilation is effective. There is no doubt. I'm just going to highlight the numbers needed to treat to reduce mortality of 8 and to reduce intubation is 5. Now, after the exacerbation, if you remain hypercapnic, you have a worse outcome. If you have acute NIV and then you remain hypercapnic, you have a very poor outcome. And so we wanted to target these patients who had persistent hypercapnia. If you have transient hypercapnia during an exacerbation, you are equally as likely to die as somebody that has a eucapnic exacerbation. So let's be clever. Let's target the patients that are most likely to benefit so we can reduce the readmission and death rate. So we took patients who were 2 to 4 weeks after an exacerbation. They had persistent hypercapnic ventilatory failure, and we treated the nocturnal hyperventilation. We were targeting admission-free survival. To meet the primary endpoint, you were dead or readmitted to hospital, both equally important to the patient. And when we had the trial design, we took patients who were hypercapnic with a CO2 greater than 52 at 2 to 4 weeks after cessation of acute non-invasive ventilation. And those patients were very severe COPD. As you can imagine, they were hypercapnic. They were severe COPD, but importantly, we excluded anybody with sleep disorder breathing, the COPD OSA. I think these patients are a completely different set from our standard COPD patients coming through. And so at 2 to 4 weeks, they got randomized. They got randomized to home oxygen therapy, or they got randomized to home oxygen therapy and home non-invasive ventilation. And indeed, the importance about a trial and anybody doing trials is to understand whether you're having a treatment effect. We know we're having a treatment effect because we had a difference between the treatment group and the control group in terms of the CO2. The CO2 was brought down in the non-invasive ventilation. The hot HMV group had a reduction in CO2. And at 12 months, that was 11 millimeters difference. So we were ventilating the patients. And so we've got a treatment that's being delivered, and our primary outcome was time to readmission or death. And what you see from time to readmission or death is, yes, the patients are coming back in both groups, but what we actually found was a significant difference in the readmission rate. And that readmission rate at 4 months was 1.4 months in the control group and 4.3 months in the treatment group. So when we look at the Kaplan-Meier and really take time when looking at these, you want to see where the separation occurs. And we saw the separation occur early. We saw a 2/3 reduction in readmission at 28 days. Now, go back to what I started with. In the UK healthcare, if somebody gets readmitted within 28 days, I get financially penalised. We have a treatment which reduces 28-day admission. We saw a 2/3 reduction in exacerbation frequency in the treatment group. Really, really important. And what we have to imagine is, although we see a 50% reduction in the likelihood of readmission or death, what I want to actually know is the absolute risk reduction. And if I know the absolute risk reduction of 17%, then I know that I need to treat 6 patients to prevent 1 readmission or death within 1 year. Let's go back to acute non-invasive ventilation. The mortality is numbers needed to treat of 8, and the intubation rate is 5. This is in the realms of acute non-invasive ventilation, but is a post-acute non-invasive ventilation. Importantly, we have more data becoming available, and this really divides people up into those who remain persistently hypercapnic at 6 weeks and those who do not remain persistently hypercapnic, with a cut-off point of 7 kilopascals or 52 millimeters of mercury. What I want to highlight is that if you were in the treatment group and your CO2 was greater than 7 at 6 weeks, you had about the same outcome of the people who were in the control group receiving oxygen treatment who had a CO2 less than 7. So CO2 seems to be a major important target for these patients. And in fact, those whose CO2 was greater than 7 in terms of the outcome receiving treatment with hot HMV, their time to readmission was actually increased and delayed compared to the group that just received the oxygen therapy. So CO2 seems to be an important signal for us to target. So you've got a clinically effective treatment. Now, when you have a clinically effective treatment, you want to see its cost effectiveness. So we did patient-level medical resource utilization. And when we did this, what we actually found, we divided this up into total service costs, total exacerbation costs, and total patient-related costs and reported costs. And the important is that obviously a ventilator is not free. So there's adverse costs with the ventilator. And that adverse cost for the ventilator is offset by the favourable cost of exacerbations and also patient-reported costs. And what you see here, adverse costs about £518 in terms of overall, but the QALY went up by 0.05, and thus the cost per QALY, which is what NICE will support, was £10,360. Now, NICE will provide treatments up to £30,000 cost per QALY. If you are in the final year of your life, and I can tell you 30% of the patients were in the final year of their life in this study, they will actually increase it to £50,000. So this is well within the limits for a cost-effective treatment as regarded by NICE, who really drives not only UK comments on treatments, but also comments in other countries as well. So it's a cost-effective. This is the cost-pain analysis, and for those who are not necessarily so au fait with these cost-pain analysis, you have less effective on the right, more effective on the left. In the upper panel, you have more expensive, and in the lower panel, less expensive. The importance is most new treatments sit exactly where that red dot is, and that is where hot HMV sits. Slightly more expensive, but significantly more effective. And when you look at it as we modelled it on the US model, what we actually found was the same story, but what we actually found, cost per QALY, because the US healthcare is so much more expensive, we found it as, and I have to say this every time, minus $50,000 cost per QALY, which is phenomenal. And this is because the bed day rates in the US are so much greater than they are in the UK. And again, you see now a treatment in the holy grail area of cost effectiveness and health economics, which is the bottom right-hand corner or the bottom right-hand panel. So does it improve outcomes? Well, I'd say it does, and if you do it 2 to 4 weeks and the CO2 is greater than 52 millimeters of mercury, then you're going to see a benefit for your patients. It's also a cost-effective as well as a clinically effective treatment. It's now incorporated into the GOLD COPD and also into NICE COPD guidelines. It's also incorporated into the Spanish, German, French, and hopefully soon, potentially the Greek guidelines, who knows. So we are driving through to make sure our patients get the best quality care based on evidence. So things to think about. Well, when we're thinking about this treatment of patients with non-invasive ventilation, we followed a strict PICO approach to enable us to understand the data. We've got the hot HMV treatment, which has proved to be clinically effective as well as cost effective. And these are incorporated into the GOLD and NICE guidance. For those interested, we now have an acute or post-acute COPD pathway, and what we do with patients who come through the acute service requiring non-invasive ventilation, they're seen at 2 to 4 weeks in our rapid access hot HMV clinic, and we will set them up in clinic on non-invasive ventilation. That wasn't necessarily the trial design, but we've just received funding for a phase 4 step wedge cluster randomized control trial to see if we can push this on so we can be setting the patients up in the outpatient service rather than the inpatient service. So admission prevention is a priority. It's a priority for your patients. It's a priority for us as clinicians. And indeed, it's a priority for healthcare organizations. We can measure neurorespiratory drive, and that will re-stratify your patients in terms of safe discharge and possibly readmission, but we're working on that data currently. If your patient post-exacerbation requiring non-invasive ventilation acutely has a high CO2 greater than 52 millimeters of mercury and a PaO2 less than 55, then at 2 to 4 weeks, you should be adding home mechanical ventilation to home oxygen therapy. And that is a cost-effective treatment in the UK, but not only less cost and more efficient in a US system. So always just remember, you want to treat the right patient at the right time in the right environment, and that ultimately will lead to a better outcome of the patients. With thanks to all the patients that have taken part in all our studies, and also to the team that I work with, which has the reason this work has moved on and we've done so well in delivering the data. And then all the patients and staff that I work with. Thank you for listening.
Thank you very much, Nicola.